My name is Jocelyn McGuire. I'm a nurse practitioner at the Hussing Family Multiple Sclerosis Center, part of Norton Neuroscience Institute. Thank you for joining me for this talk on incontinence and intimacy in multiple sclerosis. The slides I'll be using for this presentation are adapted from a previous presentation on this subject by Dr. Anna Bite. Please be conscious of who is around you as you watch this presentation, as some parts may not be suitable for all audiences. I have no disclosures relevant to this presentation. I have served on advisory boards for EMD Serono and Alexion in the past. I will first cover bladder dysfunction and multiple sclerosis. I'll discuss types of bladder dysfunction and treatments for bladder dysfunction. I will then discuss sexual dysfunction and MS, including categories of sexual dysfunction in MS and treatment of sexual dysfunction. Bladder dysfunction is a very common symptom affecting about 80% of people with MS. It occurs when there is a problem with signal transmission from the central nervous system to the bladder or sphincters. Here's an overview of bladder anatomy in males and females. Things to note in helping to understand bladder dysfunction are the smooth muscle surrounding the bladder, the sphincters, and the urethra. Common symptoms of bladder dysfunction in MS include incontinence, difficulty fully emptying the bladder, hesitancy, urgency of urination, and frequency of urination, including nighttime frequency or nocturia. The first type of bladder dysfunction I'll cover is storage dysfunction, also known as overactive bladder. In normal bladder function, as the bladder slowly fills, it sends signals to the brain and the bladder muscles push urine into the urethra. When people with MS have overactive bladder, the bladder and the central nervous system do not effectively communicate, so the bladder muscles may contract before the bladder is full. This miscommunication can also cause an emptying dysfunction and urinary retention. Symptoms include urgency, dribbling, hesitancy, and incontinence. The first step in treating bladder dysfunction is to make behavioral interventions. These include limiting bladder irritants, such as caffeine and alcohol. Ensure adequate water intake. Limiting fluids can actually worsen bladder dysfunction by increasing the risk for a urinary tract infection. However, try to restrict fluids 2 hours before bedtime. Pelvic floor therapy or exercises on your own can help strengthen the muscles around the bladder. Lastly, try timed voids by urinating every 2 hours while awake. Other treatment options for overactive bladder or storage dysfunction include anticholinergic medications like oxybutynine, tolterodine, and trospium chloride, and smooth muscle relaxers like mirabegron. If medications are not effective, then botulinum toxin or Botox injections is an option. For emptying dysfunction, intermittent self-catheterization is often recommended. For combined storage and emptying dysfunction, other medications may be used, such as antispasticity medications like baclofen or tizanidine, or alpha-adrenergic blocking medications such as tamsulosin or doxazosin. The next part of this presentation will cover sexual dysfunction and multiple sclerosis. Sexual dysfunction is very common in people with MS and in the general population. It may affect about 91% of men with MS and about 72% of women with MS. Sexual dysfunction can have a major impact on mood, self-esteem, self-confidence, relationships, and quality of life. Sexual dysfunction in MS can be categorized into primary, secondary, and tertiary causes. Primary causes are those caused by neurological dysfunction itself. Secondary causes are those caused by MS symptoms, and tertiary causes are those caused by body image and perceptions of disability. Primary causes of sexual dysfunction include erectile dysfunction, decreased genital sensation or unpleasant sensations known as paresthesias, decreased libido, lack of adequate lubrication, and difficulty reaching orgasm or premature or delayed ejaculation. Treatment for erectile dysfunction includes medications like sildenafil and tadalafil, or using a vacuum assistive device. Another part of the treatment includes reducing or stopping medications that may contribute to erectile dysfunction, such as some antidepressant medications like fluoxetine, sertraline, citalopram, and escitalopram. Treatment of decreased genital sensations or unpleasant sensations include using vibrators and other devices to increase stimulation. Part of the treatment also is to manage paresthesias, the unpleasant genital sensations. This is typically managed with medication. For managing decreased vaginal lubrication, using a water-soluble lubricant before and during sexual activity can also be helpful. To manage decreased libido, reduce or change medications that can contribute to this, such as SSRI antidepressants. Cognitive behavioral therapy can also address this. The medication philbanserin is an option for females. Secondary sexual dysfunction is related to MS symptoms such as fatigue, bladder and bowel dysfunction, and spasticity, which includes muscle tightness, cramps, and spasms. Managing these symptoms can lead to improvement in sexual function. Tertiary sexual dysfunction includes issues related to body image and changing roles. For example, a couple may have difficulty transitioning between the caregiver and care receiver roles and being intimate partners. Treatment for these include cognitive behavioral therapy or couples counseling. In conclusion, bladder dysfunction and sexual dysfunction are very common in multiple sclerosis. These below-the-belt MS symptoms can have a serious impact on quality of life. If these symptoms impact you, don't hesitate to discuss with your provider and explore treatment options.